like wading through complex medical guidelines is like trying to cross a vast ocean of dense information. What if we told you there's a shortcut to being truly well-informed, packed with surprising facts and genuine aha moments? Welcome to the Deep Dive.
Today, we're embarking on an important deep dive into the brand new British Society of Gastroenterology guidelines on inflammatory bowel disease, specifically for adults. These 2025 guidelines are a truly comprehensive update, and our mission is to extract the most important nuggets of knowledge and insight for you.
And you're right, these aren't just, minor tweaks. They represent a significant leap forward in IBD management. What's particularly noteworthy is that these guidelines are built on rigorous methodology, including the grade system.
Great, okay. Yeah, and this isn't just a technical detail. It marks a pivotal shift, moving IBD management from sometimes, well, best guess, to a truly data-driven, unified approach. This means clearer, evidence-based recommendations, leading to less variability in care and, hopefully, more predictable outcomes for patients across the board. It's about understanding not just what to do, but deeply understanding why it matters.
That distinction between what and why is definitely key.
Right.
So let's unpack this a bit. How are experts approaching the initial diagnosis of IBD today, and what advancements are truly transforming how they keep an eye on it once it's established?
Okay, well, for initial diagnosis, particularly at that very first presentation, the guidelines unequivocally state that an ileocolonoscopy is necessary for a reliable diagnosis.
Still the gold standard, then?
It truly remains the gold standard, and crucially, it requires meticulous biopsy collection. We're talking at least 2 samples from the terminal ileum, at least 4 different colonic segments, and the rectum.
Right.
All with very clear labeling of their origin.
That level of precision in labeling sounds incredibly important. What's the underlying reason for that requirement?
It's essential because IBD therapy can actually alter tissue features, you see.
Oh.
So having that pristine, well-documented baseline from before treatment begins is absolutely critical for accurate subtyping and for reliable comparisons down the line. The Montreal Phenotypic Classification System also continues to provide that consistent framework for categorizing IBD.
Okay. Now, one area that immediately caught my eye in these guidelines is how they're advocating for a truly holistic view when monitoring IBD, extending far beyond just, how a patient feels day to day. What does this comprehensive multimodal strategy look like for both ulcerative colitis and Crohn's disease?
Yeah, it's really about combining multiple streams of information: clinical assessment, biochemical markers, advanced imaging, and endoscopy with histology. A key player in this strategy is fecal calprotectin.
Calprotectin, right. Heard a lot about that.
Exactly. It's proven to be a very reliable indicator of mucosal healing and underlying disease activity. For ulcerative colitis, the guidelines offer some practical thresholds.
Like specific numbers.
Yes. So a calprotectin level below 100 micrograms per gram strongly suggests endoscopic remission.
Okay, under 100.
Levels between 100 and 200 nancers indicate an intermediate probability, sort of a gray area.
Mm-hmm.
And anything over 200 nancers should prompt a discussion about the need for a lower gastrointestinal endoscopy.
Got it. And when it comes to advanced imaging, like MRI or CT scans, how are these guidelines shaping their use, particularly given concerns about patient exposure?
Well, this is where we see a critical connection to long-term patient health, specifically radiation exposure. The guidelines now strongly prefer magnetic resonance interrography, or MRE, and intestinal ultrasound, IUS, over CT scans for evaluating both liminal and extraluminal disease in Crohn's disease.
So the priority here is long-term safety, especially for younger patients. Is that the main driver?
Precisely. This shift is especially important for children and young adults, aiming to significantly limit their lifetime radiation risk because, IBD patients, particularly those with Crohn's, can be exposed to more than twice the radiation of those with UC over their lifetime.
Wow, that's significant.
It is. And while MRE is often preferred as a first-line option for diagnosis and determining disease extent, IUS offers real-time information and doesn't require bowel preparation.
That's handy.
Significantly increasing its utility for ongoing monitoring where it's available, of course.
That makes a lot of sense for long-term care. Now, zooming in on the microscopic level, what's histology's evolving role in assessing remission? You might think no inflammation, no problem is the ultimate goal, but these guidelines seem to introduce a fascinating nuance here.
You're right, it is nuanced. For ulcerative colitis, while histological remission, meaning the absence of inflammation at a microscopic level, does indeed indicate a deeper level of healing and can predict better outcomes,
Uh-huh.
it is not a mandatory treatment target.
Not mandatory.
And for Crohn's disease, the guidelines also stress that histological remission is not a mandatory treatment target either. This is partly because biopsy appearances may not fully reflect the transmural or full-thickness nature of Crohn's disease, making it less representative of overall disease control.
Right, because Crohn's goes deeper.
Exactly. So this allows clinicians to focus on a broader picture of remission.
So with diagnosis and monitoring refined, what do these updates mean for actively managing the disease once it's confirmed? The sheer number of treatment options can feel complex, but these guidelines seem to offer clear guidance. Let's start with the conventional therapies, the sort of first steps.
Indeed. The journey often begins with conventional therapies. For mild to moderate ulcerative colitis, 5-ASAs or aminosalicylates are the first-line treatment. Topical forms like suppositories or enemas show remarkable efficacy for proctitis due to their direct mucosal concentration.
Right, direct delivery.
And combining oral and topical 5-ASAs can be even more effective. But, and this is critical to remember, 5-ASAs are not suggested for Crohn's disease.
Okay, only UC for those.
Correct. They simply don't have the same impact in Crohn's.
And what about corticosteroids, those familiar anti-inflammatories often used for flares? Are they still central?
They're certainly suggested for inducing remission in moderate to severe UC in Crohn's disease as they work quickly. That's their strength. However, the guidelines strongly advise against their long-term use for maintenance due to the well-known and significant side effects.
Yeah, everyone knows about steroid side effects.
Exactly. For Crohn's disease specifically, their use should generally be limited to no more than 8 weeks.
8 weeks max, okay. And purine analogs like azathioprine or mercaptopurine often used for longer-term management.
They are, yes, but they have a slow onset of action, so they're not for an immediate crisis. The guidelines highlight the importance of preemptive TPMT and NUDT15 genetic testing.
Genetic testing, why is that?
Well, these tests are crucial for understanding how a patient metabolizes these drugs. It's particularly important for East and South Asian patients, where certain genetic variations are more common and can lead to severe side effects.
Like what sort of side effects?
Things like pancreatitis or bone marrow suppression, which can be really serious. So this genetic information, combined with ongoing metabolite monitoring, helps optimize dosing and minimize those risks.
Right, personalized medicine in action there. Now, this is an area where the treatment landscape has truly transformed, offering more targeted and, well, powerful approaches for patients. Tell us about the advanced therapies, the biologics, and small molecules.
You're right, it's a rapidly evolving field. Anti-TNF therapies like infliximab and adalimumab are widely recommended for moderate to severe UC and Crohn's disease. For Crohn's disease, infliximab is actually recommended in combination with purine analogs.
Combination, why is that better?
The evidence points to improved efficacy and, importantly, a reduced risk of the body developing antibodies against the drug when used together. Make it last longer, essentially.
Okay. But I've heard that some of these more potent medications come with risks, including concerns about lymphoma. How does that factor into the decision-making process for patients and clinicians?
That's a vital discussion for shared decision-making, absolutely. The nuance here is important. Anti-TNF monotherapy carries a similar lymphoma risk to thiocurine monotherapy. It's there, but comparable.
Right.
However, the combination therapy with anti-TNF and purine analogs shows a significantly higher risk.
Higher? How much higher?
The pooled incidence rate ratio is about 3.71 compared to 2.23 for anti-TNF monotherapy. So it's a noticeable increase. This increased risk is something that absolutely needs to be carefully discussed with patients so they can make informed choices based on their individual situation.
Definitely sounds like a key conversation. And what about the non-anti-TNF biologics, like vedolizumab and ustekinumab? Where do they fit into the picture?
They are important alternatives. Vedolizumab's gut-specific action makes it a particularly suitable option for patients perhaps at higher risk of complications from broader immunosuppression, as it tends to have fewer systemic side effects. It targets the gut more directly.
More targeted, okay. Now, a really big step forward in this field seems to be the advent of oral medications in the advanced therapy class, not just injections or infusions. What are the key takeaways for the new JK inhibitors, like tafasitamab or upadacitinib?
Yeah, their oral administration is a huge advantage for many patients just in terms of convenience.
Taking a pill versus an infusion.
Yeah, exactly. Notably, upadacitinib is the first oral agent shown to be effective for both induction and maintenance of remission in Crohn's disease. That's a milestone.
Both phases, okay.
However, it's crucial to acknowledge the safety considerations. Non-IBD studies have indicated an increased risk of major adverse cardiac events, MAC, venous thromboembolism, VTE, and malignancy.
So heart issues, clots, cancer risk.
Yes, those are the main concerns flagged. These drugs should be used with careful consideration of benefits versus risks, especially in patients over 65, those with cardiovascular risk factors, or a history of smoking.
So very careful patient selection is needed.
Absolutely, a very individualized approach.
With all these powerful medications, how do the guidelines advise on therapeutic drug monitoring? Or TDM? That's measuring drug levels in the blood, right?
That's right. Proactive TDM, where drug doses are adjusted based on planned measurements of serum drug levels, has been robustly associated with a decreased risk of treatment failure and hospitalization in patients on anti-TNF therapies.
So that helps optimize the anti-TNFs.
Yes, for anti-TNFs, the evidence is quite strong. However, it's important to clarify that there is currently no established role for TDM in people receiving non-anti-TNF advanced therapies like vedolizumab or ustekinumab.
No TDM for those yet. Why not?
Just inconsistent data on its clinical utility for those specific drugs so far. The link between drug level and outcome isn't as clear yet.
Okay. And before we move on, what about exclusive enteral nutrition, or EETN? It sounds like a non-pharmacological, maybe dietary-based option.
That's right. EIN is briefly explained as an effective non-pharmacological option for inducing remission, especially highlighted in pediatric Crohn's disease, where it's used a lot.
Primarily kids, then.
Traditionally, yes, but the good news for adults is that a practical guide is now available for its use in this population, expanding its applicability beyond just pediatric care. So it's becoming more of an option for adults, too.
Interesting. Now, as you can imagine, managing a chronic condition like IBD also means being prepared for acute situations, which can sometimes be, well, medical emergencies. Let's talk about crisis management, starting with acute severe ulcerative colitis.
ASC.
Right. ASC is indeed a life-threatening medical emergency. Initial treatment is always high-dose intravenous corticosteroids, straight in with the big guns.
Why IV steroids first? What if they don't work?
Good question. If there's no response after 3 days of IV steroids, rescue therapies like intravenous infliximab or cyclosporin are used. The urgency here is paramount.
And I imagine early surgical consultation is absolutely critical in such a rapidly evolving situation.
It truly is. Early referral and close communication with specialist colorectal surgical and stomach care teams is advised, because subtotal colectomy may be required if medical therapy fails or if complications like toxic megacolon arise. Toxic megacolon, yeah, sounds serious.
It is. Time is absolutely of the essence in ASUC.
Beyond these severe flares, patients with IBD can also be susceptible to other infections that might mimic a flare. What should clinicians and patients be aware of regarding these superinfections?
Yeah, that's a really important point. It's vital to differentiate a true IBD flare from a superinfection. Patients presenting with new or worsening symptoms need prompt stool cultures, especially to rule out Clostridioides difficile, C. diff.
C. diff, okay. Anything else?
Another hidden culprit can be cytomegalovirus, or CMV. It's surprisingly common, present in maybe 10–30% of steroid-refractory IBD patients.
Really, that high?
It can be. And stressing diagnosis here, it relies on colonic tissue immunohistochemistry, or PCR, because serum tests don't correlate well with actual gut infection.
So you need a biopsy for CMV?
Often, yes, or PCR on the tissue. If a decision has been made to treat, ganciclovir is the recommended therapy.
Okay. When it comes to surgery for IBD, it truly sounds like a real team effort, given all the complexities involved.
It certainly is. The guidelines strongly reinforce the need for a wider multidisciplinary team, the MDT.
Who's typically on that team?
It includes IBD physicians, surgeons, radiologists, dietitians, psychologists, subspecialist nurses, and even peer support for all patients undergoing IBD surgery. This ensures holistic pre- and post-operative care.
Makes sense. And what about medication management around surgery? Should patients typically stop their IBD medications? This seems like a critical decision point with potentially big consequences.
Yeah, this is a key update with important practical implications. For elective IBD surgery, corticosteroids should ideally be stopped or their dose reduced beforehand to minimize the risk of postoperative complications.
Reduce steroids before surgery.
Right. And if a patient has been on oral corticosteroids for more than 4 weeks, they should receive an equivalent intravenous dose of hydrocortisone perioperatively, just as a protective measure against adrenal suppression.
Okay, but what about the biologics, the anti-TNFs and others?
Well, here's the crucial update. Anti-TNF and anti-integrin therapies like vedolizumab and ustekinumab can be continued in the perioperative period.
Can be continued, so no need to stop them.
Generally, no. Recent studies show no increased risk of postoperative or infectious complications. This is a huge benefit because it avoids potential disease flares that could occur if these essential medications were stopped right before surgery.
That's a significant change that could truly prevent a major setback for patients. That's great news. And for patients who've had surgery for ulcerative colitis, maybe pouch surgery, and then develop pouchitis, what does the guidance say about managing that?
Good question. For those experiencing symptoms after pouch surgery, a comprehensive assessment is needed. First, pelvic MRI, stool culture, C. difficile assay, and pouchoscopy to really pinpoint the cause.
Rule everything out.
Exactly. First-line treatment for acute pouchitis is typically a 2-week course of antibiotics like ciprofloxacin or metronidazole. For chronic refractory cases, vedolizumab is now suggested as a first-line therapy.
Veto for chronic pouchitis. Interesting. Okay, shifting gears a bit. It's easy to focus just on the gut, but IBD affects so much more than that. This deep dive clearly lays out how the new guidelines embrace a truly holistic approach to patient care, acknowledging the broader impact of the disease. Let's start with anemia, which is a common companion to IBD, isn't it?
Iron deficiency anemia is indeed very common in IBD, especially with active disease. What's important to grasp here is that oral iron tablets should not be used in those with active inflammation.
Why not? Just give them iron pills.
Because inflammation actually inhibits iron absorption, making them largely ineffective, and they can also cause gut upset, which you don't want.
Okay, so IV iron might be better then.
Often, yes, in active disease. In inactive disease, oral iron can be tried, but no more than 100 milligram elemental iron daily is advised. Also, it's worth noting that ferritin levels, which we usually use to check iron stores, can be falsely elevated by inflammation. So even a ferritin up to 100 micrograms per liter might still mean iron deficiency if there's active inflammation.
So you need other tests.
Measuring transferrin saturation gives a clear picture in that context. And of course, other causes of anemia like B12 or folate deficiency must also be considered.
Right, it's not always iron. Now, for many patients, especially women, IBD in pregnancy is a huge area of concern. What kind of clear, evidence-based guidance do these guidelines offer?
Providing clear, evidence-based guidance is absolutely vital here. You're right. The good news is 5 ASAs and purine analogs are generally considered safe during pregnancy.
Okay, that's reassuring. What about the biologics? Anti-TNFs?
For anti-TNF therapies like infliximab and adalimumab, they are also generally safe, and continuation throughout pregnancy is strongly advised.
Keep taking them, even during pregnancy.
Yes, because stopping them can significantly increase the risk of disease relapse for the mother, and an active flare during pregnancy is generally more harmful to both mother and baby than continuing the medication.
Makes sense. Are there any drugs that are definite no-nos?
Yes, and this is a critical safety point. JA inhibitors like tofacitinib and upadacitinib and the S1P modulators are contraindicated during conception, pregnancy, and lactation.
Contraindicated means absolutely avoid.
Absolutely avoid. This is due to serious malformations observed in animal studies. It's a non-negotiable safety warning.
Okay, very important distinction. Beyond the physical symptoms, psychological well-being and fatigue are often described as, well, invisible burdens for many living with IBD. Do these guidelines address those crucial aspects of patient care?
They absolutely do, and it's a crucial step forward for holistic care. The guidelines acknowledge the significant overlap between IBD and IBS, irritable bowel syndrome.
Right, symptoms can be similar sometimes.
Exactly. So they recommend following BSG-IBS guidelines for those coexisting symptoms. They also emphasize that psychological therapies, such as CBT or mindfulness, can be offered as an adjunct to routine medical care.
Adjunct meaning in addition to, not instead of.
Precisely. While they don't directly impact the underlying disease activity or inflammation, they can significantly improve symptom control and overall quality of life. Fatigue is also recognized as a profound concern. When no correctable medical cause is found, like anemia or vitamin deficiencies, non-pharmacological interventions like regular exercise, vitamin D supplementation, or even acupuncture are recommended.
Good to see fatigue being addressed. Now, this next point from the guidelines involves a truly surprising fact, one that seems almost counterintuitive, but the conclusion is crystal clear. What's the deal with smoking and IBD?
Ah, yes, the smoking paradox. It's fascinating, particularly for ulcerative colitis.
Paradox. How so?
Well, smoking is actually associated with better outcomes for UC patients' less severe disease, reduced colectomy rates. And for those with UC, stopping smoking can paradoxically worsen their condition.
Wait, stopping smoking makes UC worse. That's bizarre.
It can, yes. However, despite this counterintuitive finding for UC, the firm guideline is unequivocal. All patients should be advised to stop smoking.
Even the UC patients, it seems to help.
Yes, because the overwhelming, well-recognized risks of smoking, cardiovascular disease, respiratory illness, cancer far outweigh any potential benefit for UC.
And for Crohn's?
For Crohn's disease, there's no paradox. Smoking unequivocally worsens the disease course, makes it more aggressive, harder to treat.
Okay, so the overall health message wins out. Stop smoking, full stop.
Exactly. While the immediate gut impact can be strange for UC, the broader health risks dictate the universal advice.
And finally, in our increasingly connected world, how is digital health technology fitting into modern IBD care? Apps, web platforms, that kind of thing.
Digital health technology is seen as a potentially useful adjunct to face-to-face interaction.
An add-on, again.
Yes. It shows promise, particularly for improving patient engagement and medication adherence and potentially reducing hospital attendances by allowing for remote monitoring or symptom tracking.
But are there any downsides?
The guidelines add a crucial caveat. Great care must be taken not to disadvantage those affected by digital poverty. Not everyone has access to smartphones or reliable internet.
Right, the digital divide.
Exactly. So alternative inclusive strategies need to be developed alongside digital tools to ensure equitable access to care for everyone.
That makes perfect sense, ensuring everyone benefits. Okay, one last thing to connect to the broader picture is the relationship between IBD and spondyloarthropathies, or SPA, things like ankylosing spondylitis or psoriatic arthritis, which are related inflammatory conditions. How do these new guidelines approach that overlap and guide treatment decisions when a patient has both?
Yeah, this raises a very important practical question for these multi-system diseases. How do we ensure optimal treatment for all manifestations without compromising either condition?
Tricky balancing act.
It is, and a multidisciplinary approach involving rheumatology is absolutely essential here. For patients with both IBD and SPA, TNF inhibitors are generally the recommended first-line treatment.
Why them specifically?
Because they are effective for both conditions, hitting two birds with one stone, so to speak. Specific JAK inhibitors like tirufacitinib and upadacitinib and other biologics like ustekinumab and risankizumab are also licensed for certain IBD types and SPAC domains, offering further options depending on the specifics.
So there are several drugs that cover both.
Yes, but crucially, some drugs used effectively in rheumatology, such as etanercept, which is an anti-TNF but works differently, and the IL-17 inhibitors should be avoided in patients with IBD.
Avoided. Why?
Because they either lack efficacy in IBD or can even risk exacerbating the bowel condition. So choosing the right drug that covers both is key. It's also worth noting that vedolizumab, while gut-specific and excellent for IBD,
The gut-targeted one we mentioned earlier.
exactly, it does not have efficacy in SPAC and may even be associated with an increased risk of arthritis for some patients, so it wouldn't be the choice if joint disease is also a major issue.
Wow. What an incredible deep dive. From the meticulous details of diagnosis and monitoring to the complexities of new therapies and that vital shift towards truly holistic patient care, it's clear that the management of IBD is becoming remarkably sophisticated and personalized.
Absolutely. These guidelines truly represent a significant step forward, offering a clearer, more evidence-based roadmap for clinicians and, importantly, for patients alike. It really underscores the importance of a nuanced understanding, balancing efficacy with safety, and crucially, with the patient's quality of life day to day.
So here's something to think about as we wrap up. As we've explored how much more we understand about IBD's impact beyond just the gut, how might this evolving understanding of complex chronic conditions change the way we approach healthcare more broadly? Are we moving from just treating the disease to truly treating the whole person? What might that look like in the future?